so that
Recording in progress.
so that I can gauge a little bit how to focus the presentation. Can people just drop in the chat maybe how familiar you are with DBT? Like if you're a DBT clinician, if you use some DBT informed practices, if you've like been to a training before, if you just like know nothing, like just kind of give me an idea of your knowledge of or use of DBT so that I don't kind of tell everybody things that they've already heard a million times.
And I can help monitor the chat as well for you. Dr. Willard saying often use DBT informed treatment with clients.
DBT informed, 3-day training, certification, a rookie, but I want to use it more. So a lot of DBT informed, some basic DBT training and psychiatry program. Okay. So we don't have any seasoned DBT clinicians. We have a lot of people who are a fan, who have had some initial training, who use it in their practice, but maybe aren't in a comprehensive DBT team. Okay, helpful. So let me go into the presentation with all of that in mind. Okay. Here we go. Okay, so today we're going to be talking about treating patients who self-injure with dialectical behavior therapy, and that's really the case that I'm going to be presenting. Although I feel like everyone can benefit from DBT. Does everyone need DBT? No. Can everyone benefit from DBT? Yes, that's what I believe. Because these are just skills that are life skills that many of us have never been taught. And it can just enrich our life and make our life, it makes life worth living for many people. And for other people, it helps people be the best them that they can be. So I also teach a DBT-based college course called Wellness and Resilience for College and Beyond. Are all those students self-injuring? No. Have they benefited from the DBT skills this semester? Some of the feedback I've gotten has been amazing, just how it's helped their everyday stress with college and relationships and work. So the awesomeness about these skills that we'll talk about is they are powerful enough to help people who are highly suicidal and self-injure, and also general enough to just help with everyday distress that is even at the point where it's not pathological. So it seems like most of you know DBT is effective for adults and adolescents, even children now. There's a model for children. And like I said, there's research in schools of a prevention model for people really who are just dysregulated. That means their emotions are dysregulated, their behaviors are dysregulated. It means that their emotions are more in control of them than they are in control of their emotions, and their emotions are driving their behaviors. So they are not able to, they are impulsively acting on their emotion in ways that are getting them into trouble, and really they aren't acting in ways that are congruent with their values, or they might not even be in touch with what their values are. And DBT helps people identify what are my values, what are my goals, and how do I learn what my emotions are and act in congruence with my values, even when my emotions want me to act in a way that's not congruent with my values. So DBT aims to replace problem behaviors with skillful behaviors. So for clients who self-injure, it's really saying, you're coming to me with this problem behavior, with this maladaptive behavior. And I don't use those words with clients. I don't say maladaptive behavior. I just say, okay, so we're self-injuring. You wouldn't be self-injuring if it wasn't doing something for you. Thinking from a behavioralist point of view, thinking that this is doing something, there's a function to this behavior. And in DBT, we're thinking that the self-injury is a form of regulation. People are dysregulated emotionally and they're dysregulated behaviorally, and self-injury is helping them regulate emotionally. It's the same thing. It doesn't have to be self-injury. It could be addiction. It could be substance use. It could be angry outbursts. It could be self-injury. You're trying to regulate. So we're trying to give you, you're not going to get rid of that maladaptive behavior until we give you something that works just as much or better. So I say, okay, so cutting is working for you. It's helping you control your emotions. You don't feel that intense emotional dysregulation. It helps you focus on the physical pain and relieve some of that mental pain, even if temporarily. So we need to give you something that does that for you before you're going to stop that. And that speaks to people because they've been told many times, you have to stop this, you have to stop this, but they haven't been told, I get why you're doing this. And we're going to give you things that are going to work just as good, if not better. And we're helping people experience their emotions without acting on them. We're saying, we're not getting rid of your negative or unwanted emotions. We all need to experience emotions. Emotions have functions, and emotions motivate us to have important functions like motivating us to action, communicating to other people, communicating to ourselves, even the emotions we don't want. Maybe our target emotions of anger or sadness or shame or guilt are important for us. We just want to have them come around less often, not be so intense and not stick around so long. But we need to be able to experience them without acting on them in ways that are going to get us into trouble, for instance, self-injury. And then how do we navigate relationships in our environment? Many people come to DBT saying, everyone calls me manipulative. And I say, I don't like that word. I always reframe it as, you may be getting what you want and need in a way that's alienating other people. But everyone needs to get their wants and needs met. Let's find ways for you to get your wants and needs met that helps you build and keep healthy relationships that are important to you, and helps you feel good about yourself. Because they're not going to stop those behaviors that they may be learned to get their wants and needs met in maybe survival situations, unless you give them those other ways to get their wants and needs met. And it also helps people create a life worth living. And it's saying DBT is not a suicide prevention program. It is not a we're not going to self-injure program. It is, we are going to create your life worth living. It is, we are going to replace a life that is empty for you and doesn't feel like it is worth living, to a life that is worth living for you, which looks different to different people. Some people say a person, some people say a pet, some people say a life goal. One teen told me, I just want to know if it gets better. That's what makes life worth living to me. The kiddo we're going to talk about today said, I want a green kitchen when I grow up. And I was like, that's awesome. Let's get you that green kitchen. So what is dialectical behavior therapy? It's supportive, it's behavioral, it's cognitive. So we think of that function of the behavior. We think of what are the thoughts that are driving the emotions and behaviors. It's skill oriented, it's replacing maladaptive behavior with skills. It's balancing acceptance and change. That's the key. DBT is a form of CBT, but the thing with DBT is it has that acceptance component. When Marshalina was creating DBT, it was all about, she was like, okay, so I'm doing CBT with people who are highly suicidal and self-injurious, and they're saying, you're trying to change me. You're saying I'm the problem. And she stopped and she's like, okay. And then she started with acceptance, and they said, you're just being my friend. You're just validating me. I'm not getting anywhere. And she's like, okay, that's not working. So she came in with this dialectic, this balance of acceptance and change strategies. And that's what was so effective in working with people who were so highly suicidal and self-injurious and often had personality disorders, formerly cluster B. And it's a collaborative relationship. It really empowers the patient. We'll talk about the patient being their own case manager. They learn how to coach themselves in the skills. It's not about them thinking, oh, what would Bridget tell me to do in this moment? It's about them becoming their own skills coach, tapping into their own wise mind of what skill is going to be helpful for me in this moment. I always say the dialectical is just a fancy philosophy term for both and. We get away from the black and white. DBT used to say black and white thinking. We go from either or to both and thinking. What usually resonates with people is, have you ever hated and loved someone at the same time? Dialectical isn't a compromise. It's just that two opposite things can be true at the same thing. At the same time, I can love my mom and hate her at the same time. And also the research evidence is not just for people who are highly suicidal and self-injured, right? It really, almost everything we've tested it for, it's found effectiveness for. So many people think it's just for borderline personality disorder or highly suicidal or harming individuals. Anything from bipolar disorder to eating disorders, to ADHD. The research in DBT has found that people with different gender identities, sexual orientations, races, ethnicities are actually overrepresented in DBT research. And this might not be as a surprise because in most RCTs they're not, but in DBT research they're overrepresented because these people are often feel so invalidated and non-accepted for so many reasons that they find their way to DBT treatment. So what's most important is the DBT assumptions is people are doing the best they can. They want to improve. And they need to do better, try harder, and be more motivated to change. That's what people get really stuck on. I'm doing the best I can. Those people who hurt me in my life are doing the best they can. And we say, okay, we're just in this treatment, the people in this treatment, in this skills group, or you and your family are doing the best you can and want to improve. And at the same time, that dialectic, we all need to do better and try harder and be more motivated to change. So I tell my students, I would just say, I'm doing my best this semester. And I miss that deadline to grade your papers, and I need to do better and be more motivated to change and get those graded on time. So I'm doing my best with some vulnerability factors I had this semester, and I need to do better. So biosocial theory underlies DBT. And what's really important about this is that there's a biological vulnerability. People come out of the womb differently. You think about siblings, even twins, and one's more sensitive, highly reactive. It's harder to soothe them. They have more they're just more colorful, more emotions, and it's harder for them to get back to their baseline. And then that interacting with a social environment that's invalidating in some way, that tells them that their thoughts, behaviors, and emotions especially do not make sense. That leads over time to chronic emotional dysregulation. And also an invalidating environment that sometimes reinforces someone being over emotional. So that means that perhaps an environment where you're okay, until the person self-injures or has a suicide attempt, and then they're like, oh, how can I help you? You know, and then the person gets all this attention, and inadvertently their support system didn't pay attention to them until they upped the ante, until they really showed them, I have to be really dysregulated for me to get my wants and needs met, for you to pay attention to me, for you to understand how bad it is. I have to show you how bad it is. When I get hospitalized, that's when people understand how bad it is. So meet Olivia. She's 15, cisgender girl of mixed ethnicity. She presents to treatment after her 12th hospitalization in 2 years, all related to self-injury or suicidal behavior. She lives with her parents and older brother in a highly rural region of West Virginia. She's attending school sporadically at best and currently failing all subjects, highly school avoided. Mother has an extensive mental health history and trauma history with frequent depressive mood episodes and inpatient hospitalizations for suicidality. Mom's currently at home on disability. Dad works 2 jobs, both as a hospital aide, overnight, and at a school working as a janitor. Her brother is diagnosed with bipolar disorder and lives at home on disability. When Olivia and her parents present to treatment, her parents go back and forth between things like, we'll do whatever we can to help. We're here for you. And I think she's just doing this for attention. What biological factors might be contributing to her emotional dysregulation? You can just shout it out or put it in the chat.
Got a chat in saying risk of bipolar disorder, hormones, bipolar, parental mental health distress.
Sure. So mood disorder, bipolar disorder in the family. Oh, yes, definitely. So definitely mood disorders in the family. Mom has depression, brother has bipolar disorder. What about environment? What in the environment might be reinforcing the chronic emotional dysregulation?
Hospital stays, being an afterthought to the other's needs.
So there's so much high need in the family. You know, brother is front and center. Parents are constantly focused on brother. Brother hardly made it through school. Brother never made it to a job. Brother's on disability. They like fought hard to get brother on disability. Mom's constantly in and out of the hospital. Dad's constantly taking care of mom. Dad's working 2 jobs. Sometimes Olivia is just an afterthought. They finally pay attention to Olivia, like, oh, Olivia's the one who's doing okay. And they finally pay attention to Olivia when Olivia is no longer in school and refuses to go to school. When Olivia gets all failing grades coming home. When Olivia self-injures, has a suicide attempt, or ends up in the hospital. That's when Olivia gets that focus on her. You know, so they are inadvertently reinforcing her emotional displays, her emotional dysregulation. And they're saying, oh, she's just trying to get attention. And that's one way to look at it, but it's also she's trying to get her wants and needs met. She's trying to get her wants and needs met for attachment and affection within her family met. And how can we do that in other ways? Because she has 2 parents who love her, who want to be active in treatment. Oh. But there's also multi-generational trauma within the household, and there are many socio-demographic risk factors and biological factors. So she presents for DBT treatment. Pre-treatment is crucial in DBT. This is a problem this is something I overlooked for a long time. I was like, let's jump into DBT treatment. You are so appropriate. And pre-treatment is crucial. DBT is a huge commitment. You have individual therapy, which is once a week for an hour. You have group skills training, which for adolescents is 1.5 hours once a week. For adults, it's 2 hours once a week. So that is 2.5 hours to 3 hours of treatment a week. Then you have phone coaching, which you encourage them to use, especially at the beginning, to call you when they're in crisis after they've tried their skills already. That's like intensive therapy. It's a huge commitment, and you're asking them to commit for at least 6 months as an adolescent and for a year as an adult. So pre-treatment is crucial. Pre-treatment is 2 to 6 sessions, depending on the need of the client or family as an adolescent. And that is really to gain commitment to the treatment. And you use strategies. There's pre-commitment strategies. And if you don't know the DBT commitment strategies, it's almost like motivational interviewing. It's how do we gain this commitment to the treatment? You're almost working through barriers to treatment before they start the individual therapy and group skills training so that you have that commitment. When people are adherent to DBT treatment, we get amazing outcomes. But they need to successfully complete treatment. And so pre-treatment is huge. And so some things we use with Olivia are things like pros and cons, okay? So pros and cons of both self-injuring, okay? What's self-injuring doing for you? And the suicide attempts. And also, you know, what are the cons? And also, what are the pros of doing this treatment? And what are the cons? And then also, what is your freedom to choose? Your freedom to choose not to do this therapy. And also, what's your absence of alternatives here? You know, if you choose not to, where's your life at? You're not in school. You haven't gone in 9 weeks. You have goals of you want to open this comic store and you want to keep this relationship with your boyfriend that's on and off. You know, so we have these goals we're trying to link to. So we're trying to link to specific goals. And how do we link to specific goals and link treatment to success with specific goals? So if we can help you be less suicidal, will that help you have a more steady relationship and sustainable relationship with your boyfriend? Will that help you graduate high school so that you can have that job? And also generating hope. Like, I know you're in hell right now, and I know the pathway out of hell. And I can help you get there, and I'm all in. I need you to be all in. And I will do it with you, but I need you to be all in there with me. And I know and we can get there. So it's that cheerleading, it's that generating hope. And then you also do things like devil's advocate, which is once you get a little commitment, you go, are you sure? This is a really long, hard treatment. Are you sure? Are you sure you can handle it? That you can do it? So there's a lot of commitment strategies that you just gauge which are most appropriate to each client. There's also ways to get people in group skills training because a lot of people are scared of group. And what a lot of people do is they say, can I just do the individual therapy? And that's a rookie thing that I did. I said, I'll just do individual skills training as part of individual therapy with people. And we know the evidence is that just doesn't work as well. It doesn't. And the purpose of individual therapy in DBT is actually to increase their motivation to stay in DBT skills training and to generalize those skills to their everyday life. So individual therapy is to support group skills training. Group skills training is the active component. It is the component that it's the active ingredient response, the mechanism of change in DBT. That's what has been found to account for the outcomes in DBT. So really getting them involved in the group skills training, is so crucial. Because these skills is what has been shown to really make the change in people's life. Mindfulness, which is really how can we focus on the present moment, non-judgmentally, without clinging to the past or focusing on the future. We know when we are clinging to the past, we're often depressed or angry. When we're focused on the future, we're often anxious. If we're in the present moment, we have more calm or neutral emotions. Distress tolerance. How do I handle crisis without making things worse? How do I accept reality for what it is, not for what I want it to be? How do I let go of it shouldn't be that way, it's not fair, and just it is what it is, and that gives me the freedom to make the change I want to make in my own life. So mindfulness and distress tolerance are acceptance skills, and then emotion, and that empowers us to make the changes we want to make in our own life to create our life worth living. Emotion regulation and interpersonal effectiveness. That emotional regulation is how do I have less negative and unwanted emotions, reduce the intensity of them and have them not stick around so long. And interpersonal effectiveness is getting what I want and need in effective ways, keeping and maintaining healthy relationships, and feeling good about myself after interpersonal interactions. And then for teens, it'll also walking the middle path. It's how do I do things in a balanced way? And it's also because in the ideal form of DBT skills groups with adolescents, it's with parents. So when Olivia went to DBT skills group, we engaged both her parents came, which was actually the best outcome. Usually we only get one parent to come. And how we did that was Olivia was like, I don't want to come to group. And we were like, I know group's scary. And I pitched these skills and I said, do you feel like any of these skills would be helpful? She's like, yeah. Well, yeah, all of them. Because she's a little bit of like, that teen who's like, ugh. And then I said, do you feel like any adults in your household could use these skills? Like, oh yeah, more than me. And I said, do you think you could get them to come with you? And she was like, well, they both need them. Do you think you could get them both to come with you? And then they both came because they wanted their kid to get better, you know? And so dad figured it out with his job, and mom came, and mom later went to adult skills group by herself after she went to adolescent skills group because mom believed in the skills that much. And this like changed a whole family. But you have to get that commitment. And the cool thing is if you start a DBT skills group or you're doing the individual therapy and you find a client, a skills group, like at WVU Medicine in Charleston or Morgantown, which have telehealth groups, which is awesome because then you can serve the remote clients. Then they can join every 6 weeks because they can join anytime there's orientation and mindfulness. So there's 2 sessions where people can join. It's an open cycle where they can join every time there's orientation and mindfulness, and then there's 6 weeks of a module, and then they can join again, which is so cool because then you have people who are super bought in, like Olivia and her parents who are like, oh, I totally didn't want to do this, and Bridget dragged me to treatment. Oh my God, this has made such a difference in my life, and I'm so much closer to my parents, and I'm back to school, and I have friends now, and just give it a chance. And them saying that to the new members means so much more than anything I can say in those commitment sessions. So I'm almost done. So there's also the stages of DBT treatment, and many people don't talk about the stages of DBT treatment. People talk about the modes of DBT treatment, but not the stages. So the first stage is what we typically think of in DBT treatment. So Olivia came in with severe behavioral discontrol, life-threatening behaviors, major threats to quality of life, not going to school. And we were just trying to get her out of hell. Okay. And what did I do immediately? We get her into skills group and teach her emotion and distress tolerance skills of how do we not make things worse in a crisis. So I was going to show you a video, but I want to get to discussion. But like the first thing I teach her was the tip skills, which some of you probably know. The tip skills are how do I tip my body chemistry to change from my sympathetic nervous system, my fight or flight, to my parasympathetic nervous system, to calm my body down fast so that I can get into my wise mind, to maybe be able to either not act on my crisis, on my emotional urges, or to maybe get into a place where I can use my change skills. But we also then got to stage 2, which is working on some of her trauma work. Because this kiddo had complex trauma. We didn't get into all those factors, but of course this kid had complex trauma. And then the cognitive restructuring. And what I mean by cognitive restructuring is that chain analysis. Chain analysis is huge in DBT. Every session you're doing a chain analysis. And you're really hearing like, I'm not doing this to annoy you. This is because we are and you teach them how to do it themselves. We are doing this detective work to figure out what are these common thoughts, feelings, and actions and emotions that are driving your problem behaviors and these consequences that are just wreaking havoc on your life. So this is like what was going on with her. Okay. So she's having these prompting events. She was confronted by someone that leads to her, her maladaptive behavior, cutting. The common link is the thought everybody hates me, which leads to a different emotion each time, shame. A different time she was denied permission to go see her boyfriend. Again, everybody hates me. Different emotion, anger, verbally abusive towards parents. Not invited to a sleepover with friends. Everybody hates me, sad, stayed in bed all weekend. We had to do this detective work to find what is that common thought that's tied to that core belief of I'm worthless, I'm unlovable. And how do we work in stage 2 to get out of that quiet desperation into ordinary happiness and unhappiness and life goals and increasing self-respect. The thing about these stages is they're not linear. She would go into stage 2 and fall back into some self-injury, into stage 1, and then we'd move up into stage 3. She got to stage 4 at times. When we ended treatment, she was probably in stage 3, but she was doing really well. It's not a linear process. And not everybody makes it to stage 4, but it is possible. So where is she now? She hasn't gotten a green kitchen yet the last time I saw her, but she was working her way towards it. And she was really excited about a life where she could get her green kitchen. She had a great relationship with her parents, a really open and honest relationship where they came to therapy every other session and were really building that relationship. Going to school, an alternative school, but went every day, and it was a trade school that really fit well for her. Had built a solid peer group, which was not those rocky relationships she was useful to, had a steady boyfriend that was a healthy relationship for her, compared to some pretty rocky ones and scary ones in the past. And had a job at a card shop, with a boss that was a really good mentor for her. So I have at the end some comprehensive programs. WVU again has telehealth, which is great because we accept people for skills group only, and people in the community can be doing the individual DBT informed individual counseling, and we can do the skills group. Because it doesn't have to be. And then we have the DBT consultation team, and we can consult with the individual therapist. And then opportunities for training. And then I will open it up.
Thank you so much, first of all, for your time and sharing your expertise with the group. But this presentation was just so wonderful and so informative with great information there. But yeah, open it up for any questions, comments from anyone. I know, Rob, you had a question a little earlier on in the presentation. I can sort of reiterate that for you and maybe get us started with questions. But he was just wondering, he was saying, am I right to believe its suitability or usage has expanded a lot in the past few years?
If we're talking about who is appropriate for DBT, yes, it just, and it's also, there's comprehensive DBT, which, is, yes, the individual therapy and the skills group and the phone coaching, and and then the DBT consultation team, that comprehensive model. And that's, especially for those high acuity patients, that's what we need to get the best outcomes. But for people, that's not needed for everyone, and what we found is DBT skills are really effective for almost any population that we have tested it for. And DBT skills groups alone are effective for some populations, especially people who are not as high acuity. Things like ADHD have done well with DBT skills group alone. I'm trying to think of some other like milder depression, not major depressive disorder or treatment-resistant depression or bipolar disorder, but actually bipolar disorder, the best evidence has been with adolescents, and it's actually not been this skills group, it's been family skills coaching. It's been individual DBT, and then the family meets together for psychoeducation and skills training for the family as a group, because we know that it's so important to have family involvement, especially with people with bipolar 1 disorder. So we have those adolescents. So that's a little bit of a different model, but we have adaptations of DBT that have just been so effective for so many people, because we see that the underlying thing in DBT that we're treating, the common treatment mechanism, is behavioral and emotional discontrol. And that is underlying so many different disorders.
Thank you so much, Dr. Billy.
Thank you, Bridget, for speaking today. This was wonderful. I just wanted to mention, you were talking about how there's skills that a lot of people can benefit from. And I've actually found that if I talk about treatment recommendations for patients in my court evaluations, I talk about it in terms of DBT skills. So, you know, they could really benefit from emotion regulation and interpersonal effectiveness. And I find that it's easier to explain to the court what I'm hoping people to gain out of therapy, and that I'm asking for something evidence-based, than it is just to say CBT for depression, which they're kind of like, what does that mean? So I found that it's a really nice way to talk about the skills that I think patients need to be building for a variety of mental health concerns too.
I think talking about the actual skills, yes, can be really helpful, because it makes sense to people. You know, for some people, just saying emotion regulation, distress tolerance, interpersonal effectiveness, mindfulness, for some people, those words just are like, oh, those make sense. For some people, those words might be too jargony, and you just kind of put those into simplistic terms, and they make sense. You know, so that's how I present it to schools, and they're like, oh, of course our kids need those skills, you know. If I say DBT, they're like, we can't do therapy in school. If I say those skills, they're like, all our kids need those skills. They were like, not just our kids, you know, who are suicidal or self-injuring need those skills. They're like, every one of our kids need those skills, especially after COVID and, you know, isolation, you know. So yes, if you say the skills, yes. And actually, when I first started out doing DBT, one of the first groups I did was with girls who were all, you know, involved with juvenile court, and I would go over there and do a DBT skills group, and they were court mandated, but the parents were not involved in that. It was just DBT informed, but they did beautifully. They did beautifully. You know, and at the beginning when I was doing them, I just believed in the skills. I also worked in an alternative school, and it was all boys, all gang involved, all diagnosed with conduct disorder by somebody else, not me. But they were all complex trauma again, and everyone's like, you can't do DBT with conduct disorder. And it's like, but it worked so well, because what was underlying that? What was underlying what was the function of all of their behaviors, you know? So they all responded really well to that.
You're gonna get Lauren on her soapbox if you start talking conduct disorder and complex trauma. We'll be here all day.
That is my soapbox, but I actually, there's another part, and I'm kind of curious to poll the group what they think. But one of the things I've always loved about DBT, from just sort of an educational perspective of training the workforce, is I think one of the things it does in the way you educate is it really is very person-centered in its approach from the get-go. And it really is about meeting people where they are instead of making people fit into other curriculums of plan. And I can't highlight how critically important I think that mindset shift is in young learners. I mean, clearly more other modalities could be adapted to be person-centered, but they're not taught that way from the get-go. And I think the push that DBT has to start with where you are instead of like assessing and going forward and all the intervention is such a different approach, just that I think it lends itself very well as just that format outside of the skill development, because there's so much overlap in the actual skills, but the philosophy is really a critical shift in therapy training. And that's something I've seen people really buy into and patients really buy into, because the approach is a bit different in just how it's taught. And I'm curious what other therapists think about that statement. I'm not a therapist, but I see that shift, especially from young learners to more seasoned clinicians. And I think DBT starts in the right place with that, which I think lends to why it's accepted better by patients. But I'm just throwing that out there.
I would agree. I also think that it's a somewhat middle ground between CBT and ACT, both of which I think are really great. But I think that DBT lets you do both, whereas ACT people get very stuck that we're not changing. And I think that's unrealistic. So I like how DBT kind of combines the two of them.
So I
Although
love,
I
I
think it
love the
existed before
dialectic. Yeah, I love the dialectic between acceptance and change, and people wrapping their heads around I'm accepting myself for who I am and where I'm at and reality for what it is. And when I do that, I'm freeing myself to make the changes that I want to see in myself and my own life and create my life worth living. And that like blows their mind when they can wrap their head around that. And it's broken record over and over with them about that. But I do like what DBT, I feel like it is so person-centered and it is so strength-based, and it also is vulnerability on behalf of the therapist. And it also is a lot of self-disclosure, which we're often not thought to do. But it's self-disclosure in the point of modeling skills. So you're showing vulnerability in that I'm not just asking you to do this. Everybody could use this. I use these skills every day. You have to, I walk the walk, I talk the talk. Like, I don't just talk the talk, I walk the walk, like I use these skills coming in today when I was sitting in traffic. I noticed that I noticed my emotion, and the intensity of my emotion didn't fit the facts of the situation. And I used this skill to, and then that's what I'm asking you to do right now. And you're showing that vulnerability, and then you're sharing that with them. And then that's also, that's modeling, and it's also helping them to match that vulnerability and to use those skills in their own life. And that comes across as very genuine for patients, and helps them engage. But you're not telling them things that are making them worry about you or switch the focus on you. They're benign examples in your life, and they're just modeling skill use and vulnerability. And I do want to get back to Ashley's question. So she was saying, so our DBT skills team, which I'm still a part of, a DBT skills group, you can be an individual therapist, and then you can have the DBT program bill for group therapy in the same week, as even in the same day, right, Lauren, as you doing individual therapy.
Yeah, I mean, it's pretty typical to combine group and individual. I mean, that's sort of the foundation of a lot of like IOPs and PHPs too. So I'm not aware of any I'm not even, they're separate codes and it's documentation differences, but you
Uh,
don't fall into that same gap where you can't have two therapists because it's a different modality and a different billing code. I don't think that's ever come up. And they usually, at least in West Virginia Medicaid, there are no quantity limits on individual or group per se
Yeah.
with an in-network provider. In fact, there actually are some for family therapy and like family therapy without. I mean, most people will override that, especially for kids. Even those limits. So it's real easy to get outpatient therapy services covered. You can even get 2 therapists services for individual covered with a request, especially if they're working together and they're very specific skill sets. So that shouldn't be a problem. That's a pretty
And with the
individual.
DBT and with the DBT program, the group therapist is not the therapist. The individual therapist is the therapist. The group is the skills training group, and they bill for group, but the therapist is the individual therapist, and the group therapist is billing for group. So the DBT group coordinates with the individual therapist, but they're in charge of group, if that makes sense. So DBT skills training group is a group. It's like if you were the individual therapist and you sent someone to an anger management group, or you sent someone to a social skills training group. No, it's a group. It's also going to a group. Actually, DBT was created for the skills group not to be billed as therapy. It's just Medicaid, Medicare, all insurance companies bill DBT skills group as therapy, because DBT can actually be performed by someone who is not master's level, because it's actually a myth that it has to be a master's level person to be DBT skills trainer.
Thank you
So
so
that's
much.
getting in the weeds a little bit.
No, that's very helpful. And Rob, you chimed in as well, saying my understanding is we try not to schedule group and individual on the same day. So individual on a day that they're not attending day hospital. And then,
Yeah, it's more helpful when individual and group aren't on the same day. I've seen it. I mean, I've done it, but sometimes it is more helpful for some people.
Yeah, so day hospital is supposed to include in its bundled rate group therapy. So that may be part of the confusion with. So some of the, like if you're designated at an IOP or partial hospital or day hospital, you get a different bundled rate for the service on that day. And it's supposed to include the treatment elements versus the outpatient, which is sort of a per diem per service sort of billing. So I'm not sure it has to do with like that. It's just that you can't bill a group on a day or a day hospital because the day hospital is supposed to include the group rate. Does that make sense?
So DBT is an outpatient group. Yeah.
I was always told that it was also the day hospital is a higher level of care than outpatient. So if you're billing both higher level of care and outpatient, it gets confusing to.
Correct.
You can't be in DBT group when you're still in IOP or day hospital. So you have to, yeah.
This is the same challenge as like when you tried to do the group on the inpatient unit, that they couldn't bill it because the group's part of the inpatient treatment rate already. So that's the only difference.
and Rob, I see you might still be muted, but I see you were chiming in there.
Yes, I'm actually here. I was talking about when we do like scheduling when somebody leaves the hospital and maybe they're going to day hospital, but they also have an outpatient therapist that they see individually. That's when we try to avoid billing on the same day.
Yeah, that's correct, because
That
they are
concerns the
different levels of care. So you are right about that.
That's what I was referring to. Yeah.
Thank you all so much. We have about a minute or two left, but I don't want to rush anyone. So, are there any other comments or questions from the group? And Dr. Bailey, I know you covered a lot there, but any final comments or things you wanted to share with the group?
No, I just thank you all for coming today and being so engaged. And please reach out if I can be of any help.
Thank you so much. And we, again, so appreciate your time and for you joining us. And you're always welcome to come back, even just to sit in on a session, and you don't have to present, but if you want to join, you're always welcome. So I want to take a moment and thank you all as well for a wonderful 2023. It's been so great. And we wish you all a wonderful holiday season and a happy new year. My only announcement is that the next time we'll meet is on January 3rd. And the ECHO team is going to sort of discuss the new iEcho platform. So we can get into details about what that is at that session. But thank you all so much. We'll see you in the new year. Take care, everyone.